So good afternoon and welcome. My name is Francesco Emman. Before starting, as usual, let me remind you that the microphones are turned off and that during and after the webinar, you can send your question that appears on your screen. I will then ask your question at the end of the webinar. Will last approximately 30 minutes. We will then have 15 minutes available for questions. So our speaker today is Roberta Fenoglio. Dr. Fenoglio is a clinical researcher in nephrology at the University of Turin, and she practices in the nephrology and dialysis unit and in the Center of Research of Immunopathology and Rare Diseases at the San Giovanni Bosco Hospital in Italy, in Turin. Today, the title of her lecture is Rituximab as a frontline therapy for adult-onset minimal change disease. Please, Roberta. Hello. Roberta, if you hear me, you can start. We seem to have a problem. At least I'm not hearing you. Roberta, please start if you can hear me. And so to all of you, please stay with us. We're trying to solve the problem. Hello, Roberta. Hello, Roberta.
Francesco, can you hear me?
I can hear you. I can hear you. You can start your broadcast. I've introduced you. So you can just start.
Sorry, I don't know what's happened. Thank you, Francesco.
Don't worry.
And, thanks everyone to be here today to attending this webinar. So as we know, the in children, minimal change disease is the most common cause of nephrotic syndrome, accounting for 17 to 19% of patients. Around puberty, this proportion decreases significantly, and in adults, as you can see in the right part of the picture, minimal change disease represents at least 10 to 5% of patients with idiopathic nephrotic syndrome. However, some other studies report percentages up to 30%. So the histologic picture of minimal change disease is identical in adults and in children, and this is defined by a nephrotic syndrome with normal appearing light microscopy and diffuse podocyte effacement on electron microscopy in the absence of cellular infiltrates or immune deposits. Although secondary causes of minimal change disease, such as drugs, infection, or lymphoproliferative disorders are uncommon in children, they account for up to 15% of minimal change in adults. Thus, it's important to assess these patients for secondary causes, as both the prognosis and the therapeutic approach are determined by underlying etiology. Although there is an abundance of data regarding the course, response to treatment and outcome in pediatric patients, much less we know about adults with minimal change disease. In both children and adults, minimal change usually presents abruptly with the sudden onset of edema and massive proteinuria. However, unlike in children, hypertension, hematuria, and renal dysfunction are more common in adults. And in some cases, in adults, they can experience progression to end-stage renal disease. Historically, the minimal change disease has been considered a T lymphocyte pathology. A hypothesis of a T-cell dependent permeability factor has been prominent for many years. However, recent advances have shown a more complex pathogenesis with the participation of innate immunity, B cells, regulatory T cells, and circulating factors. Knowledge of basic immunology, together with results deriving from animal models of the disease, suggest a complex interaction of factors and cells, starting from the activation of innate immunity and continue with antigen presentation. CD80 and CD40 likely play a relevant role at the start. In general, the role of adaptive immunity is supported by findings in animal models of minimal change nephropathy relative to CD80. This is a stimulatory molecule expressed by the antigen-presenting cells and by B cells that is part of the so-called immunologic synapse, regulating a balance between immunology activation and its block. CD40 is another co-stimulatory molecule involved in adaptive immunity, and high serum levels of anti-CD40 antibodies have been reported recently in association with the recurrence of proteinuria in more severe forms of minimal change nephropathy. CD40 belongs to the TNF gene superfamily, expressed preferentially on B lymphocytes, monocytes, and dendritic cells. Binding of CD40 to its ligand expressed on T lymphocytes and platelets triggers an inflammatory process with significant consequences. Podocytes directly may be involved in the early immune response. Oxidants produced by circulating cells in the early immune response may be toxic for podocytes, and Tregs reduce the oxidative impact by metabolizing ATP to adenosine. Under inflammatory stimuli, podocytes express both toll-like receptor and CD80 and become a part of the initial immune response. Podocytes also express CD40, whose stimulation by soluble ligand induces the redistribution and loss of nephrin and increases albumin permeability in isolated red glomeruli. As a consequence of this knowledge, nowadays the pathogenesis of minimal change nephropathy is considered multifactorial. At the start, it is based on an innate immunity with activation of CD80 by professional cells such as B cells and tool-like receptor. Oxidants are upregulated in this first phase and may represent a trigger of pathology if not blunted adequately. The second step is based on an alternative evolution. One possibility is the prevalence of an anti-inflammatory pathway based on the activation respectively of T effector by interleukin 7 and 2 and of T helper 17 by interleukin 6 and TGF beta that produce podocytes lesions. The second possibility is Treg expansion, and while CD80 is preeminent in the first phase as the regulatory system, Tregs and ATP drive the anti-inflammatory phase. Although B cells have never been characterized in minimal change nephropathy, the suggestion of their implication derives from studies on the successful use of anti-CD20 monoclonal antibodies to treat this disease. Despite the positive results reported in the literature, the therapeutic effect of rituximab has not been defined univocal. The positive efficacy of rituximab via its effect on a pool of circulating and/or tissue-residing B cells could seem surprising. However, now we know that there are many interactions between B and T cells in lymphatic tissue, and the suppression of B cells could have effects on the properties of T cells, a subset of which might be the source of the elusive permeability factor of minimal change disease. Since B cells activate T helper cells through antigen presentation, depletion of B cells might alter T cell function or subpopulation expansion. Alternatively, the beneficial effects of rituximab may be mediated through restoration of or upregulation of T regulatory cells. Recently, the results of this trial suggest that relapses are associated with the inhibition of interleukin-2 production and a loss of Treg cells alongside an expansion of a particular memory T cell subset, while remission are associated with downregulation of a T cell subset. This new T cell subset identified in this study may have a potential impact on T cell and B cell cooperation. This could be targeted by rituximab therapy and highlights that this disease can be a disorder of innate and adaptive immune response. Another putative mechanism suggested by Fornoni is that rituximab promotes the stabilization of the podocyte cytoskeleton and prevents apoptosis through interaction with the glomerular epithelial cells, thus indicating that the role of rituximab in the management of steroid-dependent nephrotic syndrome is not solely attributable to the removal of B cells. Rituximab can bind to human podocytes in vitro, possibly through the sphingomyelin phosphodiesterase acid-like 3B protein, known to have a negative regulation on to the signal of tool-like receptor. While podocytes do not express CD20, it is postulated that direct binding of rituximab to sphingomyelin could prevent actin cytoskeletal changes, thereby maintaining cell integrity. The first case that was reported in literature of the successful use of rituximab in the management of minimal change disease in adults was published in 27. In this report, a patient with multirelapsing nephrotic syndrome secondary to minimal change disease who failed previous treatment with all other potentially steroid-sparing drugs was treated with rituximab at the standard dose, and the longer-term remission was achieved after therapy. Since this publication, several other papers on the successful use of rituximab in the setting of frequent relapses and steroids dependence have been published. But today, no randomized controlled trial have been conducted in adults examining the efficacy of rituximab as a first-line therapy. In 2018, we reported our first experience on 6 adults with biopsy-proven minimal change disease who were treated with anti-CD20 antibodies as a frontline therapy. They received 4 weekly infusions of rituximab at the standard doses. And as you can see in the right part of the slide, proteinuria decreased from 11.2 to 0.6 grams per day after 6 months, and to 0.4 in the 4 patients with the longer follow-up. Creatinine decreased from 1.9 to 0.9 milligram deciliter, and 5 patients achieved a complete renal remission, while in 1 patient, the proteinuria decreased by 75%. Rituximab successfully depleted the CD19 lymphocytes in all patients for at least 6 months, and no clinically relevant adverse events were observed. We conclude that rituximab given alone is an effective alternative and safe also in frontline therapy in adult patients with minimal change disease, and it could be preferred in patients at high risk of developing the several adverse effects of corticosteroids. A few months ago, this systematic review and meta-analysis on rituximab for minimal change in adults was published. It included a total of 11 studies, and all of them were observational studies. It included a total of 170 patients with minimal change, and the overall remission rate and relapse rate of rituximab therapy was 80.3% and about 36% respectively. Complete remission rate occurred in about 75%, and the subgroup analysis showed that overall remission and relapse were not different after adjusted for study year and the rituximab dose. Incidence of serious adverse events was low, and the authors so concluded that rituximab could be considered as an additional treatment to the standard therapy for adult patients with a minimal change. Based on these results, the 2019 KDIGO review considered rituximab as a possible alternative for adult minimal change disease. To date, a randomized control trial is ongoing to investigate the value of rituximab in adult minimal change disease. So most studies focused on a single course regimens, and very few evaluated the efficacy of rituximab as a maintenance therapy. Due to the risk of cumulative steroid dose, reducing relapse frequency is considered now a critical issue, and the possible role of rituximab as a maintenance regimen to achieve longer relapse-free survival has been addressed. This is the history of Andrea. He had a diagnosis of minimal change disease when he was 16 months old, and the course of the disease was marked by frequent relapses and steroid dependence. He failed treatment with all other potentially steroid-sparing drugs, including cyclophosphamide, cyclosporin, tacrolimus, and mycophenolate. And at the age of 18, he began being followed in our hospital. He had no other health problem, and his medication at that time was 2 mg tacrolimus twice a day, 500 mg mycophenolate twice a day, and 5 mg prednisone every day. Since he had a relapse, we performed a second biopsy to confirm the previous diagnosis, and rituximab was started at standard doses. For the 6 months after therapy, tacrolimus and mycophenolate were stopped. After 6 months, CD19 cells reappeared, and within a few weeks, the patient experienced a new relapse. He received another dose of rituximab and again achieved a complete remission. The same thing happened at the 12th month, and so we decided to start a maintenance therapy to obtain a persistent negative CD19 count. This strategy has been for now successful. During the last year, he has remained in remission and he has no adverse events. The prednisone was stopped and now he is therapy-free. Here are the profile of IgG and cholesterol level, and here of the albumin, and as you can see, the level are consonant with the history of proteinuria and relapse. The association between relapse and CD19 positive B cells has been reported in many studies, where B cells reappeared prior to relapse in most cases. Therefore, it's important to monitor and predict CD19 positive B cell repopulation. In our patient, CD19 cells were clinically depleted following rituximab administration, and they have been observed to reappear prior to relapse, suggesting that the reappearance of B cells can be a predictive of relapse. And the aim of this study, this prospective study, was to evaluate the efficacy and safety of a standard dose of rituximab in maintaining remission of minimal change disease, reducing relapse frequency, and withdrawing immunosuppression in a group of adult patients with frequently relapsing and steroid-dependent minimal change disease. All patients were in remission at the start of the treatment and on a calcineurin inhibitor. 2 doses of rituximab, 1 gram, were given 6 months apart, and a subset of patients also received an additional dose 12 months later in order to examine the benefit of retreatment. As you can see in the panel A of the slide, a single dose of rituximab successfully depleted CD19 lymphocytes in 86% of patients, and CD19 cells progressively re-emerged in the circulation 6-12 months following each infusion of rituximab. As you can see in the right part of the slide, most relapses occurred with CD19 counts of 100 or greater, and 2 relapses occurred below this level in the same patient. A similar association between B cell recovery and relapse has been reported in other studies. In particular, in a Japanese cohort of 25 adult minimal change disease patients treated with a similar rituximab protocol, no relapses were observed during the B-cell depletion period, and in another one, in a French cohort of 17 patients, the majority of relapses were observed after reappearance of CD19. Data from the pediatric population also suggest that maintaining prolonged B-cell depletion with repeated rituximab infusions reduce relapse frequency. However, in many studies, patients were given a single course regimen, including 4 infusions weekly. In other study, 2 infusions administered 2 weeks apart, and in other study, a single dose infusion was used. Most of these studies reported a reduction in relapse frequency, improvement of relapse-free survival, but long-term outcomes was not necessarily satisfactory, and some patients relapsed. Takei conducted a prospective trial of rituximab maintenance therapy in 25 adults with steroid-dependent nephrotic syndrome. The patients were administered a single dose of rituximab for a fixed period every 6 months. They reported that the total number of relapses and dose of prednisolone after administration of rituximab decreased. However, most patients in this study were limited to young patients with a mean age at the start of the rituximab treatment of 30 years. So, on this basis, the efficacy of rituximab maintenance therapy, even in older minimal change disease patients, remains unclear. And so, can we extend these results to all patients, in particular to elderly patients as well? This is the history of a 72-year-old patient who presented with bilateral leg swelling due to nephrotic syndrome and acute kidney injury. He was overweight, and a renal biopsy demonstrated the presence of a minimal change nephropathy. Due to the presence of multiple risk factors for adverse steroid effects, the patient was treated with rituximab at the standard dose. CD19 cells were depleted immediately, and the patient did not show relapse even after the reappearance of B cells 12 months later and during the entire follow-up. Similarly to our patients, previous studies did not show the reappearance of B cell to be inexorably followed by relapse, suggesting individual differences of response to rituximab irrespective of B cell depletion. Conversely, others reported frequent relapses also in elderly patients. And in this study, Taguchi retrospectively reviewed the clinical course of 13 biopsy-proven adult minimal change patients receiving rituximab and evaluated the relapse rate, concomitant steroid and immunosuppressant use, relationship between B-cell depletion time and relapse, and adverse event. Mean patient age at the start of therapy was 51.5, and the authors reported a significantly decreased median relapse frequency and a reduced median prednisolone dose. CD19 positive B cells remained depleted during rituximab administration at fixed doses at 7 months intervals. No serious adverse events were observed after rituximab administration, and so the authors concluded that a repeat dose of rituximab as a maintenance therapy can be efficient to prevent recurrence also in elderly patients. Thus, on these results, should rituximab be prescribed as maintenance therapy to all patients? And if so, should it be given at the fixed doses or based on B cell count? This is our extended experience that confirms that the initial results. We treated 12 patients with rituximab monotherapy as frontline. All but one achieved a complete remission, and this patient achieved a complete remission after a second course of rituximab 15 months later. 2 patients relapsed after 24 and 10 months respectively, and patient 12 was retreated with one single dose of rituximab and again achieved a complete response. After this relapse, maintenance therapy was scheduled and the patient is now free from other relapse. Patient 11 started a second course of rituximab that is currently ongoing. 9 out of 12 patients experienced no relapse despite a prolonged follow-up, and therefore maintenance therapy was not necessary. So coming back to the question, the answer is that our results suggest that maintenance therapy is not for all. However, our patients were facing their first episode of minimal change disease. Interestingly, all other studies in literature refer to patients with frequent relapses. How can we decide which is the optimal protocol for our patients? And for example, in these 2 patients, can we consider the different age at disease onset as the single factor influencing the different response to the same therapy? Factors associated with the relapse in adults are not well known. Lee, in this retrospective study, aim to identify predictors of relapse in adult-onset minimal change disease. A cohort of 195 patients with adult-onset minimal change disease was followed up for more than 12 months. The clinical characteristics of relapse and its predictors in adult minimal change disease patients were examined, and the results confirm that adult onset is relatively benign disease in terms of long-term renal and patient outcome. However, the results show that more than 2/3 of adult onset minimal change disease patients experience relapse more than once after diagnosis. In addition, younger onset age, degree of mesangial proliferation, lower serum albumin level, shorter initial immunosuppressive treatment, and were found to be independent risk factors for relapse in adult onset. Incidentally, calcineurin inhibitors and intravenous corticosteroids pulse therapy did not show any protective effect on relapse in this retrospective cohort. However, these predictors are not sufficient to decide which patient need a maintenance therapy in real life, mainly in naive patients. If we come back to our patients to analyze the predictors of relapse, we know that patient 11 and patient 12 had different age at the onset. Serum albumin levels were low in both patients who relapsed, but they were not different from those of many other patients. Moreover, there were no significant difference in histological characteristics. and the duration of treatment was the same for all patients. In our case, patients who relapsed had a shorter follow-up than others. So if we compare patient 11 with patient 8, we see that clinical characteristics are not so different, but today patient 8 has no experience any relapse despite a longer follow-up. So on this basis, further studies are needed to definitively identify patients who can benefit from maintenance therapy. Another open question is whether a low dose of rituximab is enough as induction therapy for adult onset of minimal change disease. Recently, Takei suggested that a single dose of rituximab administered at baseline and at month 6 may be a safe and efficient alternative in adult patients with minimal change nephropathy. However, although 95% of children attain remission with the steroid therapy by 8 weeks, only 50 to 75% of adults do so. It is not until after 16 weeks of treatment that most adults enter remission, with the majority attaining complete remission and a minority attaining a partial remission. While the protocols for rituximab infusion vary among centers, it is worth noting that, as reported by the German registry, the duration of remission of patients receiving 1 or 2 infusions of rituximab was much shorter than in patients receiving 3 or 4 infusions of rituximab. Not surprisingly, the peripheral B cell counts significantly increase 6 months after the first single dose injection of rituximab, and increase again at 12 months, and all of the patients who developed relapse were found to have B cell repopulation. Nevertheless, the authors concluded that the low dose of rituximab was protective against the relapse and reduces the total dose of prednisolone needed. In this other study, Ruggianenti evaluated the effects of rituximab therapy followed by immunosuppression withdrawal on disease recurrence in 10 children and 20 adults with minimal change disease or focal segmental glomerulosclerosis. And these patients suffered 2 recurrences over the previous year and were in steroid-induced remission. Participants receive 1 or 2 doses of rituximab, and compare with the year before rituximab treatment, total relapses decreases, the per patient steroid maintenance median dose decreased, and the median cumulative dose to achieve relapse remission decrease. This reduction was significant across subgroups of study. After rituximab administration, CD19 B lymphocytes were promptly and fully depleted and progressively re-emerged into the circulation from 6 to 1 year. In participants without relapses, the reduction in circulating B cells at different time points versus baseline was significant through the whole study period, whereas the difference was no longer significant from day 240 up to the study end in patients with relapses. The authors concluded that rituximab effectively and safely prevented recurrence and reduced the need for immunosuppression in steroid-dependent or frequently relapsing nephrotic syndrome. However, it must be emphasized that all these patients treated with low-dose rituximab were in remission at that time. And so, to date, we don't know if the same conclusions could be translated to patients who were treated in the course of relapse. So, in conclusion, we can say that minimal change disease is a disease with a complex etiology. Although the prognosis is generally good, failure to find a definitive treatment strategy remains a challenge. Current evidence supports the use of rituximab in adult minimal change disease, also as a frontline therapy. Serious adverse effects of rituximab are uncommon, and optimal dose of rituximab in minimal change disease patients remain to be established. Thank you for your attention.
Well, thank you very much, Roberta. This was a very interesting webinar, and we can now maybe move to the question that you prepare for us. In the meantime, I'm trying to get hold of my questions, because I've lost the question that you are sending in. Hopefully I will be able to recover them. Thank you. So can you see the questions, or should I ask them, Roberta?
I can see the questions, Francesco.
So you can, so please go ahead.
Okay.
Please go ahead. You can read the questions, and so can you see them or not? I didn't get it.
Yeah.
Do you see them?
No, no.
Okay, then I will read them because I can see
Yes.
them.
Yes.
So the first question is on adult minimal change disease. Is it always secondary to another cause? Can it be secondary to another cause? Is never secondary to another cause, or is never drug associated? Please vote. All right, I think that we can. Okay, so can you see the result? Should I read them to you?
Yes, I can see. And I see that the majority answered that can be secondary to another cause, and this is correct. This is an important point because there is a difference between adults and children, and so before starting any therapy is fundamental to exclude a secondary cause, in particular an infection or a tumor condition.
Okay, so the next question is, in the pathogenesis of minimal change disease, do podocyte maybe are podocyte maybe directly involved? Tregs increase the oxidative impact. Oxidants are downregulated. CD80 and CD40, CD4 ligands have a secondary role. So please vote your answer. All right, I think that most people have voted, and here are the answers. Can you see them?
Yes, yes. So the majority answered that podocytes may be directly involved, and this is right, because they are involved in the early immune response, and some products, we told that in early immune response may be toxic for podocytes, and so this is true.
All right, next question. Rituximab can be useful in minimal change disease treatment only in pediatric patients, only in previously untreated patients, in patients with frequent relapses, only in elderly patients.
Roberta, can you see the results?
Yes.
Okay.
So the audience has not doubted. 98% answered that rituximab can be useful in patients with frequent relapse, and so is what the literature now say that report. As I say, that is that we have only studies that reports of patients with frequent relapser and steroid-dependent patients. So we now are convinced that rituximab can be an alternative also as frontline therapy, but what we can say is that is sure the role of rituximab in frequent relapse.
All right. The next question is about rituximab maintenance therapy. Is it indicated in all patients? Does it prevent relapses? Is it never indicated? Or is it burdened with many side effects?
More distributed, the answer are more distributed.
So here again, I think we have saturated our answers.
Okay, here the answer are more sparse because someone think that the maintenance is indicated in all patients. Some other think that is burdened with the many side effects, but the major part of the audience answered that the maintenance therapy can prevent relapse. And this last is what we discuss about. All the studies report a reduction in number of relapses after maintenance therapy. The question is which patients need that maintenance therapy. To date, we have not sufficient elements to decide who treat and for many months, how long to continue the maintenance therapy.
All right, and do we have a last question? Or are we done with the questions?
We are done with the questions.
Okay, so Roberta, I have a few. So it's 4:50 here, so we have to close the webinar in 10 minutes. But you do have a few questions. So Dr. Wetzel is asking whether patients are steroid sensitive or resistant. And the comment is that such information is lost when using rituximab as first therapy. You did not see non-responders to rituximab, question mark. Also, tacrolimus monotherapy is an option. What about tacrolimus versus rituximab in the current COVID era?
So first of all, the use of rituximab as a frontline therapy, yes, is this can the possibility to miss the information about resistance or dependence by steroids is an important point. However, we choose to use this protocol in patients who had many factor risk for steroids adverse events. And so I think that it's important to balance these two problems. And this is mainly true for patients that are, for elderly patients, in which is important to avoid steroid adverse events. And about the use of rituximab and tacrolimus in the COVID era, I have not a definitive idea. I think we, in our experience, haven't a serious problem in patients that treated with rituximab and positive for COVID. And we experienced now in the last weeks only one case that in which rituximab was used for another indication, not for minimal change. And he remained asymptomatic and hadn't any problem.
Thank you. And I think that this is really an open question that is coming up, and we're all been wondering which immunosuppressive drug is less toxic or exposes less to viral infection, whether it's a calcineurin inhibitor, an MMF, or a rituximab. And I think that we're still lacking a good answer to this question. So Dr. Sawiris, and I always apologize if I don't pronounce well your last name, is asking your opinion about rituximab in cyclosporine-resistant nephrotic syndrome.
Okay. But I think that rituximab can be a useful alternative for all patients. It's important to see the answer to the first course of rituximab, and so I think that we have resistant patients. It's hopeful to try to use rituximab. I think that some difference there are if the patient is pediatric or adult, but in all cases that we use the rituximab in adults also with resistance to the previous treatment, we had we obtained good results.
All right, and I have a last question for you from Dr. Mirioglu. Are there any data regarding combined use of rituximab and MMF in steroid-dependent minimal change disease? It may result in less repeated doses of rituximab, but maybe an increase in late-onset neutropenia. Any data about this issue? This is the question.
So we haven't any experience with the use of rituximab in combination with any other drug. We use rituximab alone in all our cases. And I can remember any experience in literature in adult onset of minimal change disease with mycophenolate and rituximab. Personally, I think that the increase of side effect, in particular in the reduction of white cells, could be a problem.
And if I may add to what you said, there is a recent paper by Dr. Chen that was published in Kidney International a few months ago that looked at 500 pediatric patients, and in that retrospective review, using MMF allowed to give less rituximab. But obviously the long-term side effects, as you mentioned, need to be prospectively investigated. At least in children, what we see is that we have a concerning high proportion of patients, especially if they're young, that develop hypogammaglobulinemia with rituximab. And this is becoming, for us at least, an increasing concern. Maybe as a last question, would you like to comment on the risk of hypogammaglobulinemia in adults treated with rituximab?
Okay, well, we didn't experience any significant hypoglobulimia in adults. I know that this is an important problem for pediatrics patients, but with the standard dose also in patients that I showed that in which we made a repeated infusion at the fixed intervals, we haven't experienced a very severe hypoglobulinemia. This is an important point to monitor during the therapy, but I think that in adult is not so significant as in pediatric population.
All right, Roberta, thank you very much. Before we end this webinar, let me please remind you the next scheduled webinars that we have. On October 6th, Olivier de Vuist will give us a webinar on autosomal dominant tubular interstitial kidney disease. On October 15th, Dr. McAllister and Roxana Schroff will give us a webinar on the clinical practice recommendation from the Pediatric Renal Nutrition Task Force on dietetic management of calcium and phosphate in children with CKD. And then on October 27, we will have a webinar from by Rosanne Topaloglu on the classification and physiopathology of vasculitis. So until then, I thank you all for your attention. Thank you again, Roberta, for your enlightening webinar, and we'll hope that you will join us for the next webinar on October 6th. Thank you very much.
Thank you. Thank you.